And with the slight eye on the
Senate.
Senate floor.
Hi, welcome back. So we're gonna kind of continue discussion around 197. We're gonna have to come back to 189. Later. Oh, after the floor today, we'll come back to 189. Jen's gonna join us up front, so let's just give her a minute to. Sorry. Take your time. Sure. Here this week. All right. So we've taken an awful lot of testimony on 197, and obviously we also have our public hearing tomorrow. Which frankly, I'm really excited about.
I'm sure.
I think it will ground us on why we're here. And what we're trying to, I'm hoping it will ground us on what problem are we trying to solve with 197.
That's on the news this morning, and it did say that it was asking for public input.
Good. Oh, good.
Yes.
Oh, exciting.
Which news?
Channel 5.
Channel 5.
Thank you, Channel 5.
Thank you, Channel 5.
And we have a lot of people signed up already. Really?
So,
Yes.
We're not at capacity yet.
Can I ask, it's
Around 40.
it's 40? That's a lot. That's a lot. I hope everybody can fit into room 11. Maybe we should have done it in the chamber. But I just wanted to get overall thoughts on, like, I mean, I thought that was a really good discussion with Dr. Soroyan, and people are really thinking about what we're doing here. I just wanted to get thoughts on like what people would like to see out of this bill. We've done 2 walkthroughs of it. We could have Jen put up the language. Maybe get an idea of what we think is good, what we think is not so good. I don't know. How does that sound to everybody?
Yeah.
It's as passed by Senate. We haven't done any, that's the as passed by Senate.
I have 3.1, is that?
3.1 was the Senate's version of 3.1. We had our thing got printed before
Yes, I
it
think.
became as passed by Senate.
But it's the same.
Yeah, that's what they passed.
I have an overall comment. That's
Really, really want to hear it. I do. That's what I'm hoping for.
Yeah.
Like everyone's overall.
I'll wait till it settles down and settled. Okay. So I have a hope and I have a concern. I won't say it's a fear because I'm not really scared. It's more like it more evokes a sense of apathy and despair than fear. My concern is that it's very reporty, and the NCSL has done research showing that legislative bodies often don't follow the recommendations of their reports. And this body has not been an exception to that. So I'm a little concerned we're going to have lots of people reporting, and without political will or vision, we're not going to do enough with what comes back to us. And I just feel bad wasting people's time and energy and taxpayer money on reports if we're not going to do anything about it. So I want us to be committed to being serious about following through on any reports that we require. And and then my hope would be that we use this as a chance to have a little bit more of a vision. And I do see hope in the idea of the blueprint becoming a foundation of something greater. And perhaps us finally delivering on the promise of Act 48, even if it's a baby step.
I love that you said that. Because the one thing that I keep thinking about this bill, there's like no vision on where we want to be.
Yeah.
And you know, I've actually been thinking about it in the concept of what we did last year in S-126 at 68. Like we set in place reference-based pricing, but we didn't actually put in there where we wanted to be. Like what were we trying to solve? So like we're moving towards reference-based pricing, but we don't have a vision on what it's supposed to even accomplish.
Other than save money, I mean, Yeah.
We don't even have anything in there.
saying that we want to do that,
That we
yeah.
want to save money. And 197 has a lot of reports, but it doesn't have any intent. Well, it does start with some intent language. Not very aspirational, I would say. But where do we want to be? Can we talk about where we want to be? Where people want to see us? Like what's our goal? This is a bill primarily about primary care.
I would like to speak like, what you said, what is our goal? I would like to answer the question in like just a
Yeah.
few sentences. So my goal would be to cultivate a system of care in which all patients have access to primary care without cost sharing, where all providers are able to make a good, honest living taking care of people, and where all payers give their fair share.
All I got down was cultivate. I hope somebody else.
It's on YouTube and you can easily watch it up to.
Can I ask a question?
Yeah.
So be back with the fact that they pay taxes on. Just don't understand.
So the way it currently works is, who pays into the blueprint is, Blue Cross Blue Shield, MVP, and Cigna pays in for their, qualified health plan people, or what's that?
Carby Legislative Council. They don't offer in the qualified health plan market. They do offer, I believe, large group.
The large group, yeah. But not necessarily their self-funded plans
Don't-
unless the self-funded plan decided that they wanted to pay into. I think at some point they said it was 2,000 Vermonters. I think we got this money last year on that. And then Medicaid obviously pays in because and Medicare used to pay in under our previous demonstration project, which has now ended. So they're not paying in currently to the blueprint. And that's like the last, I don't know if you remember in the budget this year, there's like bridge funding. That was essentially the state paying what Medicare used to pay. And the whole point was to get us to the new demonstration project ahead, which keeps moving out.
Ahead.
Well, I don't want to say it's moving ahead. It just keeps getting pushed back.
So my question, I mean, is it possible to have all these entities put more, or is it pretty much?
Apparently there's a lawsuit.
There's not a lawsuit. I would say it's unclear. As I understand it, so that the state is preempted under federal law from regulating the self-funded plans that are administered by third-party administrators. There is some ability for the state to regulate third-party administrators. As I understand the way programs are currently implemented, the blueprint contributions are not coming from third-party administrators on behalf of the self-funded plans. Whether they could, I think is an open question. The lawsuit, the litigation that Dr. Soroyan mentioned had to do with our all-parent claims database and whether we could require third-party administrators to report their self-funded contract claims to for VCures, the all-parent claims database. So I don't want to conflate the two because they're different. We do, as I understand currently, the claims tax, the healthcare claims tax is paid on behalf of all claims that have accrued from services to Vermonters, people covered by plans regulated or offered to people from the state, whether they are administered by third-party administrators or fully commercially insured insurers. So I think it's an open question.
And maybe Nolan can help get. Does Medicare or Medicaid pay the claims tax? I'm assuming no. Just on private insurance.
And that's largely because we cannot tax the federal government and we don't tax the state. We are the state.
Yeah. Really super clear, isn't it? Dave, did you have?
I know, no.
Oh, sorry. Thank God. Leslie?
Well, I think I'm trying to understand what S-197 is about in a way. Because is it just a payment reform bill? Or is it a bill that really is exploring the role of primary care in our healthcare system and how we believe that primary care is essential to improve health of Vermonters, and so that we're investing bigger than just a payment reform system. And it seems like an opportunity that I don't want to let go by. From an aspirational point of view, that we can just do more of the same. And right now it feels like it's a little bit more of the same. Maybe, as we were talking earlier, just spreading more of the same, but I'm not really sure how. When you look at the numbers, a lot of people are already involved. The health, the HSA. So I'm not sure the changes. I'm a little hazy on that. And how this bill does anything other than a lot of reports. I would like to see a real commitment to increasing primary care spend and really talk about that and what our goals would be and what we're asking for. That's a big deal, I know, but we know it's 35% of healthcare and only 5% of the spend. So how do we get from here to there? So is this bill the vehicle for that? I mean, I was hoping so. But I don't know that the intent section is strong enough because it is only about payment reform. And I think we've learned enough about primary care to understand the essential role it plays.
Yeah. Why do we keep studying it?
Yeah, why do we keep studying it?
We already know the answers.
Because we already know that we want to, so yeah. What do we need to know in order to actually do something? Don't we know enough now to actually do something?
And I found both the measures, we keep seeing the same measures on all of these, like it's diabetes or hypertension, I find the measures lame. I do, as a provider myself there, in my opinion right now, we're all not well, and we can't measure that by your blood pressure or your, there's just no good way to measure how we're affecting good health in a primary care setting. Do we need a diagnosis? Do we need, what is it that we need to say that good care is happening in a primary care setting?
I know I've been harping on quality measures. I know some of you are probably not really thrilled with me.
No, I hate it.
This is a citizen legislature, and this is a discussion. So I'm gonna bring my own personal, I worked for close to 30 years in a practice. These quality measures, this is somebody like me sitting down in an office documenting that a measure was met. And I don't know what the value. Like I think about they always use the same too, the diabetes with the hemoglobin A1C under 7. First of all, to even think that it provides 9, okay, 9, it was 7. The fact that the implication is that a healthcare provider, and this is why I keep going back to that, it's really about the relationship between the patient and the provider. It's in the payer's best interest that everybody have a hemoglobin A1C under 9. Does anyone really think that a provider is going to be sitting there with their patient with uncontrolled diabetes and not care in trying to get that person's diabetes under control? And then to measure whether or not you've been able to get your patient's diabetes under control completely removes like all the social determinants of health and the things that are in that person's life that is a challenge for them. I mean, is it great that you have a community health team so that you can have, a dietitian to be able to, that you have access to the resources that your patients really need, which is what I think the beauty of the Blueprint actually is that they provide the resources so that a provider with that unique relationship with that one patient has the ability to be able to connect that patient with services that can actually help get their diabetes under control. But to pay a provider an extra quarter because they're treating to the tests means that we don't trust that a provider cares about whether or not somebody's diabetes is in control or not, or hypertension. So what do? You over-medicate somebody so that they become hypotensive, which is not great either. And it's as if somebody would be sitting in front of you and they have hypertension and you don't even address it or care about it. You're a provider. That's why I keep harping on quality measures. That, and it's somebody like me sitting in an office, going into every single individual diabetic's charts and coming up with a CPT2 code to be able to report to an insurance company what that person's hemoglobin A1C was. What difference does it make?
Mhm.
I totally disagree.
I know you
And
do.
Alyssa and she knows I totally disagree. I think quality and accountability need measurement. I think you can't, Leslie, you can't change what you don't measure, including your diabetes. And I think we have standards in American healthcare. Healthcare is a science. And that's why we need to measure it. I don't trust all doctors. Heck no. There are bad actors out there. And it's unfortunate. And I don't think that, measuring is at all about not trusting them. But I think it's about having high standards of care, about safety. It's about also efficiencies, right? If we maintain level standards, it's easier to align and have expectations, and also I think systems learning across our system. So I think the measurements are absolutely worth it. How are we gonna have our facilities be accredited or certified? I'm not going somewhere that's not accredited. We talked about that when we talked about the health plans in, what bill was that, 585? I'm not going somewhere that's not accredited. And if you're not measuring all this stuff, you're not following the NCQA, you're not gonna be accredited.
But we have lots of practices that don't go for NCQA accreditation.
I'm not going there.
Well,
I'm just saying, I disagree with you. And this is a citizen legislature, so
Yes, I
I'm
know.
making my point.
I
Thank you
think
very
it
much.
reduces somebody, a patient, as somebody who has practiced, it reduces somebody to a diabetic. They're no longer a person in the practice. They are a diabetic that you're treating that disease. I think you have to look at the overall patient. If we're just reducing it to a diagnosis, then that's what they're getting paid for. I think it totally changes the trajectory and how you're treating that patient. Is how I look at it. Diabetes is on their chart. You're looking at it every time they go in. I just hate the way they measure it in that way. What if I go in? I'm not a diabetic. How the doctor's going to get paid less because I don't have a standout diagnosis that can be measured every time? I just look at it like it should be a whole person. It should not be a diagnosis that we're looking at every time someone goes into a doctor's office.
I think it's like the blueprint we are, right? We want people to get healthy, and that sometimes is incrementally addressing health problems, right?
But every single time they go in, we're going to just measure that one thing, and that's going to be how they're reimbursed. And the doctor has to be laser focused on that one thing in order to get reimbursed accordingly. I don't know, I just find this backwards.
Brian and then Leslie.
So I guess I would start by saying I agree that we've created a system where our efforts to improve quality they drive a culture where people then search for how to do that. So like now the money flows towards coders to look for how do you make as much money as you can, to look at how do you document, you provide, we have to worry about providing the proper document. It's like making providers jump over hurdles or through flaming hoops and then giving them a treat. But then they figure out how to jump through that hoop better. It doesn't necessarily solve the problem. So I think we have to be careful about that. I question how far do we go with quality measurement, and like, what are we really measuring? And like, just as an example of that, like the Trump administration just announced $139 million in grants to transform behavioral health. And they're looking at things like, just one example I'll give you. Wearing continuous wearable device data interlinked with electronic health records at, quote, unprecedented scale to predict and prevent behavioral health disorders and promote healthy behaviors. So are we going to have people wearing collars, now where their medical record's going to be recording their behavior, and then you know what I mean? Like, where are we going? Where is this headed? So I think we have to be careful about that. Like that to me seems extreme, honestly. I mean, granted, I wouldn't mind making money for not smoking if there was like, I can get like $10 a day and they were tracking me to make sure I didn't smoke. I don't know. So maybe there's a benefit to that, but like, I think we need to really think about like, how far are we gonna go to track quality and what's really valuable or not? And I did email you all that little thing I said earlier. I wrote it down and emailed it to everyone.
Just now.
Well, like a minute ago.
That's, yeah, I was thinking that just now. That qualifies.
You did remind me of something, which is, like, we have had a profound loss of independent practices. And we hear from practices all the time about administrative burden. And when you add these layers of like quality and administration, it incentivizes and rewards the scale that is able to have administrators administrating, and you cannot have a individual or a small practice be able to, I'm not going to say game the system, but a lot of quality measures and meeting it is gaming the system to get the payments. And when you are so small, you cannot game the system because you don't have. And that is one of the reasons that we know administrative burden is why we're losing independent practices. And we're trying in this committee, we talk about it all the time. Independent primary care, independent healthcare is frankly has higher quality measures and cost a lot less for the system. And we're trying to sort of remove our primary care from a hospital-based setting because we know that it's driving up costs. And, a lot of what we've done in an effort to improve quality has ironically flipped it, and it's causing behavior that we didn't want in the first place. Leslie?
I was really thinking about drivers of health when you brought, at the same moment you said it, I thought it. And I think it's pretty well established that medicine only contributes to 20% of a person's health. But look at the amount that we're investing in this very tiny, narrow piece of it. And I'm sitting here wondering, well, maybe this is just a payment reform bill and nothing more than that for primary care. And leave it at that and not think about anything more than doing what we can do to improve primary care sustainability. And when Dr. Rabin was here, I thought, God, I said, I want you to be my doctor, right? She was like amazing. And I had this vision of all these tiny little independent primary care practices, all over with people having access. And as you all know, I did primary care for 37 years. It's really hard to change people's behavior when SNAP benefits are paying for soda. Your A1C is going to be high. I don't care. I could add more drugs, but that's my only recourse. And that is not a sustainable process. It just puts money in pharmaceutical pockets. So it's a lot of frustration about what actually changes behavior and what actually makes people healthier. And I'm not sure that we're in a position to start to do that in this bill. But I do think we can do primary care payment reform and really have targets. We want 50, like Massachusetts, like you said, we want 15% by 2030. I don't care, whatever. I'm making that up. But actually pressure the system to put money into primary care and support independent practices. I worked in independent practice. I stopped working in independent practice because getting paid was impossible. It was horrible. So I walked away and got employed by a hospital. So until that system is doable, we're going to have people employed by a hospital because someone wants to do that administrative nonsense. So all of it is a morass. And what I would love to see is this bill simplify it all so that primary care gets supported.
Here?
I just had a question about the language in the bill. And as introduced, it says, one of the goals was to reduce the amount of time primary care practitioners spend on administrative tasks from an average of 50% of practitioner time to an average of 10% of practitioner time. Is that still in the bill that we're looking at?
If you believe so,
Yeah, we have to.
Really? it takes a different, the bill that came to you takes a different approach
Okay.
to primary care.
Administrative. Can you point to us where it took the turn in the bill that we have in front of us? You said that it took a different approach to administrative, where,
No, it just took a different approach to the primary care issues.
Oh, okay.
It's, they don't recall if there's anything.
It just seems like a terrible waste of human capability to provide quality healthcare to have it be spent in this way. And it's sort of a measurable metric on that issue.
let's have our administrative burden representative. She'd know the iterations of that.
Jessica Barnard, Vermont Medical Society, I would say where the bill addresses that currently is less through a specific measure or number, but asking you've tasked, well, the bill currently is drafted tasks a group coming back with more of a concrete payment reform proposal, and that group would look at how to measure quality and what quality measures would use. So rather, it doesn't have a set goal, but it does include that in any next iterations of payment reform as a serious consideration.
What about the administrative thing that Karen was talking about?
It does not include that same measure of the hours. I think there was a lot of conversation even among primary care clinicians of what it is included in that statistic. And actually a concern that one concern of if you are measuring that in terms of hours, are you just then hours of clinician time? And that speaking of practicing to the tests, do you then just hire more administrative staff to do those tasks? And we're not actually simplifying the administrative tasks. So is that actually accomplishing the goal? When you're just looking at the hours of clinical time spent on administrative spaces or administrative requirements.
Didn't we get testimony at some point on what would be the right sized percentage to provide this kind of care?
Percentage of what?
Of funding for primary care providers versus like.
Percentage of total spend, healthcare spending.
I guess because it was just, we, provide 35% of the care, 5% of the spend. And there was something in the teams, I seem to remember 15% or something, that was somehow something that would truly work.
Yeah, we took testimony on, because there is, and the bill started frankly differently, and if you remember, we walked through, I don't remember the number now, but 433. No,
Incremental.
the other one where basically it's contemplates like a Rhode Island system of ratcheting up
Yeah.
the percent.
There is,
A total
the bill that came to you does ask the agency to establish a target.
Because we also heard testimony that primary care providers are providing a bunch of care for free because their full patient needs that kind of care. But if you are talking about where the money is spent in the system-wide, like perhaps a specialist isn't providing care for free. I don't know, it just seems that the care that's being provided should be able to be complete and thorough and paid at a rate that recognizes that specialty of taking care of the whole person. So just in terms of vision, I'd like to. Every-
I am gonna put a question out there, keeping in mind what Karen just talked about, like the vision of a percent of spend. I wanted to get everyone's thoughts on Dr. Song, which is, I believe, what Massachusetts is working on. The idea that primary care is a public utility and a common fund. What did everyone think of that when he was sort of presenting it to us?
I loved that. I just really thought that made a lot of sense. It's so inequitable now and on so many different levels. That just made a lot of sense.
I think when you change the vocabulary of things, you change the trajectory of things. And I think that did it for me. Like if you start talking about it differently to people, they'll change. Like I said, I think right now when people get sick, what do? They go to the emergency room, they cut themselves, they go to the emergency, it's just been this, it's the way we think now. But if you take primary care out of the system and make it the utility that it is, and change the conversation around it, I just think we could make it something great. We really could. The doctors we've had in here have been awesome. Like I would go to any one of them. Well, the exception of one, but. Which one?
I was gonna ask, no, no,
No,
ask.
no, that was rhetorical. Yes, it was. Totally.
Anybody else want to weigh in on the common fund?
Just one little addition, if you think about, I guess maybe I'm channeling Bernie a little bit here, but if you think about the money we already do spend.
Yeah.
On administrative stuff, if we just took that same pile, put it in here. Quality care, accessible to all, equity.
I agree. The way we talk about things can change the culture and change the way we do things. I do believe that this committee, for at least as long as I've been on it and before that, probably deep down has believed that. And the real question is, how do you make it happen? And yes, we spend a lot of money on healthcare. And this committee and other committees have tried for many years to move that needle, and it hasn't worked. So that's what I want to get to. I don't care what we call it, but how do we finally move that needle?
I think it's a really great point. What you're saying, which kind of ties to Leslie about what is this bill anyways? And this bill seems to be, we talk an awful lot about transformation in this committee. And what I find things that were supposed to be transformed really just become sustainability. Is this transforming primary care and the mechanism in which we pay for it? Or is it just making it more sustainable? Because all the efforts that we put in the past, which you just alluded to, I've kind of built on this model, which has become unsustainable. Should we just prop up and sustain this, or should we think of a new funding model? Yeah.
So, and I know.
The question to you.
Yeah, so I know I've missed some of the testimony and I apologize for that, but when I read this bill, I think we are doing more of the same because it doesn't matter what the blueprint comes back and says they need to make it, make it work funding wise. It's still our requirement as a state to put that money in, and we've never been able to do that. My thought.
Thank you.
Yeah, you'd say
Thank
something.
you. I got Alan, and then I got Daisy.
Okay, the first line on page 1, an act relating to payment reform for primary care. There's a lot of other stuff in here that's happening without addressing primary care. That, me, that's confusing. I think with all the reports and everything else, it's unwarranted. And I think we should get back to reforming primary care. And And the other thing we haven't realized, and I don't know, maybe I'm not that up on it, but the transformation of rural healthcare. I think that's gonna have an effect down the road. I don't know what year, but are we gonna put ourselves in a predicament that that's gonna hinder us? If, you know, who knows what's in there? I don't, but. I think that's primary care is gonna be, within the 5 years, is gonna be on the table.
To your point, frankly, I'm not sure I see anything in the bill that actually doesn't pertain to primary
I think
care.
it all does.
It's a lot of different reports.
Exactly.
But we talk about rural, particularly rural primary care, because that's,
The whole thing.
should we be continuing a payment model that has led to deep inequities between rural and more suburban? I'm not using urban, so we really don't have any urban. Should we be moving to a payment model that actually is far more equitable to rural?
The whole, according to transformation, the whole state's rule, right? I think they've eliminated Chittenden County or Burlington. Yes. So.
It depends the measure.
Yeah, that's true. And the other thing is, we talked about prevention. And you talk about diabetes. I have a primary care doctor. You could look at me and say, hey, he doesn't follow the directions of his doctors. I got primary care. He tells me what to do. He tells me what medicine. He tells me how to do this. He goes to, I've never been to a dietitian. You can't make people do something that they don't do. So I don't care how much you pay a primary care or Blueprint for Health to give you the right areas to go to. It takes people to do what they're told, I guess.
You make a great point, which is we're currently measuring your primary care provider on what we can't make do.
Exactly.
Right. But let me ask you a question. First of all, I should ask you, do you value your primary care provider?
Yes.
You like them? Okay,
Yes.
great. Do you like them because they hound you about your hemoglobin A1C? Or do you like them because you think they care about you?
We're friends. We've become friends. I've been going here for probably 35 years. We become friends. We talk openly about my health. And what do I tell him? No, I haven't lost weight. He keeps telling me that, but it takes two. You know, the primary care can direct you, Blueprint for Health can direct you, but the patient has to be part of the solution.
So what you value is your long-term relationship with your friend.
Yeah,
That's immeasurable.
it is.
So what makes the patient part of the solution?
Because when he tells me if he tells me to take my sugar count every day and I take it every 2 weeks, I'm not following orders.
So what would it take? So that's one of the questions. What would it take? And I don't,
In today's society.
you wrote it up, but I don't want to put you on the
No,
spot.
I don't matter. Go
Okay,
ahead.
because you're just sort of this model person that we just have an opportunity to
Yes.
think about. I mean, we all have our version, right?
Yeah.
Some of us smoke cigarettes, whatever.
Yeah, yes.
So, sorry.
Cigarettes.
Social. You guys don't even know my bad habits because they're private, right? So our pet, we all have them.
It's so.
That was good.
So I guess the question is, how do we engage people? How do we engage someone like, all of us who have our quirks and
We tried.
and I don't know that answer.
We've tried to engage people and educate people on their health now for years and years.
But the point is, what you're saying is that we're measuring primary care providers on what people are not engaging in
Right.
managing their own health. And does this bill do more of that? And so are we perpetuating that bad, dynamic?
I think you're more likely to have more trust in your provider and what their recommendations are if you trust them that they care about you. So if you don't have a relationship with your provider, a longitudinal 30-year relationship, you're less likely to trust that provider when they recommend, that you get a pneumovax. You're more likely to trust them when they say, hey, let's switch you to this medication. I mean, not Alan, but you're more likely to test your blood sugar every day instead of every 2 weeks. If you have a trusting relationship with somebody.
But 30 years is 30 years, right? And even with a 30-year relationship. So, okay, we put a lot of emphasis on primary care and relationship, and the more I hear, the less I'm convinced, even though we all love, being around someone we're comfortable with and, feel they care for us, but it's not changing behavior. So what then? I'm getting to
So why should the primary care be dependent on someone like Alan to get paid more?
That's what I just said, right?
I know, and I mean that with all due respect, but if you knew that your doctor might get a little bump in pay, would you do the right thing? Like it's.
And if Alan gets sent to the endocrinologist because he wants to test his blood sugars, why is the endocrinologist not getting paid based upon
That's right.
his? That's the thing I struggle with.
That's right.
You had
And I wanted to.
Oh, Daisy, yes.
Oh,
It's gone.
sorry, I'm sorry. How do we know that our colleague here doesn't have a better health outcome in being with us here today because he had that 35?
Yeah.
I think it's hard, no.
I'm sure he did.
There could be a lot of positives that we're not
No, that's a good point.
seeing or measuring and, and that it has been good.
Which is why I have a problem with measuring.
A couple thoughts. One, I don't think, I'm with Daisy that we can't get rid of quality measures. I do believe we should, and this committee has tried to coordinate, align, all of that, right? And how do we make sure we're measuring the right things to know we have qualified people and are making our population healthier? So I don't think should throw it out. I do think we need to find a way to make it work. The second thing is we keep talking about 30-year relationships with our providers. I think we need to remember that those of us that are younger than the people at this table, not me, all of us, younger than us, that's not how they use healthcare.
Exactly.
Right. And so we haven't talked about that. So I think about, my son and his friends and they're turning 18, right? And they're going to be able to do their own thing. They're not going to look for a doctor that they have a long-term relationship with. It's not, if we were in other states, they'd be going to CVS to get their health care or Costco or something. So I think we need to keep that in the back of our minds as we start looking at this. I see we need to reform payment to providers and we need to reduce and align quality measures that make sense to make the population healthier.
But don't call it transformation.
Daisy recalled her.
I know what I was gonna say. It's just that, we're sitting here in this room and yes, we've had lots of testimony through this year about what we need to make better and ideas of how to do it, and great testimony from folks like Dr. Song, which I thought was very interesting, intriguing, and I think there's so much we don't know, and it seems outrageous that we would sit around this table and between the 11, 12 of us come up with how to fix healthcare in Vermont. That's absolutely outrageous. And I think that we need someone to tell us what to do. And that's why I look forward to this public hearing, because I think we can't discount. And I'm not suggesting that anyone at this table has. I know we all really share respect and value for what people, what patients and providers are gonna tell us they need us to change for them. But I just think, you know, looking at this bill, it's yes, more of the same. Too complicated. And three, like, I want to hear, what do my constituents think of it? Is it gonna fix the fact that like they can't even afford to get to any of these providers? I don't know. I feel like I'm really looking forward to hearing from the public about this bill. I'm not jazzed about it. I don't think it changes that much.
I'm so excited for Thursday. Really,
Yeah,
I
me too.
really, I want to hear what people value. And no offense to anyone sitting around the room, because you're all, you know, you have really important perspectives. But,
Oh my
sorry,
God.
Somebody-
My wearable device just told my medical record. Yeah.
I have Leslie.
I think we have an opportunity to do something beyond this bill. And I really hope we can. I think, and that's important. If it's not beyond this bill, then I don't really care. I think it's just more the same. So I am, and I said this earlier, but I'm just gonna say it again, really intrigued in the idea of primary care as a public utility. And that's a common good. And we talked about that, you know, we talked about it in the context of hospitals, so they're a common good, right? But okay, so let's say primary care is a common good. Let's agree with that, or public utility, as he was talking about. And making a case for a common fund. And I am very interested. That would take us beyond where we are. And I really would like to see that.
And would not cost us to start any more than what we spend right now. To carry
It's the
this
same,
It's the same amount.
It's a 5%, it's the same
But
thing.
5%, everybody puts 5% into the common fund.
But it expands who puts in.
Yes.
And
it
that's what's
expands who puts in. Yeah.
That's a really important start. And then how it gets distributed.
And then we can talk about things like, okay, we start with 5%. And then how do we build upon that? And which gets to the point of like, I think how this bill started and the other bill that we had on our wall of like the spend targets, where it would be a much easier mechanism to essentially have, you know, to be able to reach those spend targets if everybody is putting into a common fund.
Yeah. Managed by the treasurer, perhaps, you know, who does that work.
Alan, did you have something? I thought.
By the way, I just got a clean bill of health the other day, just to finish that off.
They're all feeling a sigh of relief.
Until they have a new measurement tool that your primary care provider can look at.
Well, say if I may, you said something really important. And one of it really depends on what you measure. And Daisy, I agree with that. But you said pneumobats. Now, what kills older people more than pneumonia? Nothing. So, and what prevents pneumonia more than anything? Pneumobats. So it's a really simple way to measure whether people are getting the primary care they need. So I think that there are measures that make sense, is all I'm saying.
Yeah. I think there are.
And this is maybe an additional benefit if we have access to primary healthcare. Many of these practitioners have said, look, I can do the dermatological list, you know, there are many things I can do without having to go to the specialist. And then we have the flexibility in employment, like does this relieve businesses? Does this allow them to do more, to grow? Does this allow, you know, the property taxes not to be spending so much money on education-related healthcare? I mean, does it actually have the effect of relieving system-wide a lot of the cost pressures we have across the board? And I just wonder, I don't know where that goes, but I always felt bad that people were stuck with maybe an employment situation they didn't want to be in or shouldn't be in because they needed healthcare, or they chose
Or married.
because, or or chose a job that maybe wasn't the best job, but there was all those things. And I love the mobility and the lifting of social cost. Oh, anyways, that's it.
And I did want to say something about quality measures, and Dr. Soroyan touched on this a little bit today. And I don't think I'm advocating getting rid of all quality measures. I think we need to modernize what we're actually measuring. And he said that. I mean, he talked about that they are in the process of modernizing the blueprint and what they measure. And I think about because the quality measures that we measure right now have been around, you know, the hypertension, the hemoglobin A1C, you know, the immunizations.
Developmental screening might be the only one that has impact for children.
Yeah, but what I was gonna say, there's an asthma one that there's going to be improvement. We have medications for diabetes that we didn't have 10 years ago. I mean, just look at GLP-1s and, you know, in the treatment of co-occurring heart disease in diabetics. We have, I was looking at one of the measures in asthma that Blueprint does and how it's gotten so much better. It's because there's actually, it's in children, there's actually now a method of inhalation that is able to be, I mean, remember we did a bill a couple of years ago and we had to put in that thing about covering asthma medication? It's because the delivery of asthma medication is better than it was 10 years ago. Like the method that kids can actually get albuterol in, or, you know, what other drugs we use.
And
I mean,
speaking of social determinants,
medications are better and they're leading to a lot of these things, which is why I'm just advocating we need to modernize and we need to measure. I just feel like we need to somehow measure the things that have been very difficult to measure because they're unmeasurable. But I mean, we've had multiple witnesses because I've asked, what would you measure? And they all come back with access and
Patient satisfaction.
patient satisfaction. And even Dr. Soroyan today said, yeah, they're kind of moving in that direction. So maybe that's what we should be basing some of this on. Yeah.
So this is very simple. I'm slowly learning how complex the healthcare system is. And I'm not setting any of that aside. I just think the bottom line in Vermont right now is affordability. I don't go to my doctor and I love her. She's fantastic. She's fantastic. But I don't go because I feel healthy. So how do you get me in there? It's affordability. I don't want another bill. So I think everything we do, everything we push, everything that is processed should just does it make it more affordable?
If everybody could go and they didn't have to worry, would people go when they needed to go rather than waiting? Your doctor, by the way, is getting measured on their quality and you're dinging them because you're not.
That's what I was just thinking.
You know.
If you get measured on your going to the doctor on a regular basis, your doctor is getting dinged because you're not going.
Yeah.
That's not gonna make my deductible go below 40,000 a year.
yeah. Two separate, it's two
It's a
separate.
great point though.
It
But
is.
it's really important. They're very distinct. It's like you're being measured on what you're not willing to do because it's too expensive. I mean, it's idiotic.
It's not.
Yeah.
Wendy, did you?
No, but I just want to say that it's definitely, we're asking doctors to be measured on something that is so abstract and subjective. Like, I'm sorry, those measures, they're always the same. They're always A1C, they're always And if you don't have those, what are we measuring? Someone showing up at a doctor's office, I think is the only other measure we really.
But we measure, have you seen someone for a preventive visit within the last amount of time,
Yes.
which
There was a measurement of ED
the
visits.
waste of a prevention. Yeah, and then there was a measure of ED visits, which are going up as we're also
Exactly.
increasing schedules being filled with.
So if you have your ED visits going up, then that's of that area.
Go ahead, Jane.
I just wanted to say that we were focused on measuring the providers when most of the power is in the hands of the patient. And that I believe someone threw out the number 20%, but the last I looked, 16% of the social drivers of health was access to care, and 34% was healthy behavior, and the other 50% were other factors. And so if 34% of what's driving health outcomes is the behavior of the people, then we should be creating policy that promotes healthy behavior. And so removing cost sharing and perhaps even providing other incentives for going for your yearly physical and providing at that, through primary care, providing better nutritional advice. I mean, I would even go so far as to say referrals to gyms and gym memberships should be part of our healthcare. Because aerobic exercise, I've learned this recently in my effort to address my issues, 150 minutes a week of aerobic exercise can prevent so many diseases and can improve mental health. And I'm having a hard time doing that because now I have to buy a gym membership, but I'm going to do it because it's cheaper than cigarettes. But that being said, but that not every human is going to come to that conclusion or put the work that I've put in to come to that conclusion without access to care. So imagine if we create ways to incentivize access to care that then incentivizes the healthy behaviors. I don't think measuring the provider's testing is the way to go. Maybe it should be how many gym memberships are being used, how much, I don't know, how many of your clients are accepting maybe it's rewarding the patient instead of the provider. Like maybe we should be like incentivized because they're the ones whose behavior matters. I don't know. I could go off about it further, but I think you get my point.
I do.
Interesting. Consistent. It's great.
Well, that was one of the other quality measures I mentioned. Like one of the biggest ones was screening for colorectal cancer.
For what?
And
Colorectal. I
and
said
it has
polio,
gotten-
and I'm like,
and the quality has gone through the roof. It's great. We also have Cologuard, which we didn't have before. Your only way to screen was a colonoscopy, which nobody ever.
what age are you supposed to get that at?
I think it's down to 40.
40, it's your family history too.
Yeah, I know. I haven't even been to a primary care physician in probably 10 years.
Dang.
They charge me too much to go for
Dang.
something that I get that's not useful. So,
All right.
sorry.
So super excited about tomorrow. I think it's gonna be great. We're gonna table our discussions on 197 because Gary, after this discussion, we obviously know exactly where we're going and. Anyway, it's great discussion. Thank you, everybody.
Before we go up, this is policy related. If anyone is interested in hearing from patients who've benefited from psychedelic therapy, we're eating lunch in the cafeteria and there's some people who have come here who would really like to connect. So feel free to find me and talk to them.
They're gonna say eating something
gonna
else.
say,
It's for lunch.
Some mushrooms. And by the way,
Wow.
I did promise, Brian, and I'm actually really super excited about it. At the end of the session, when we're kind of in that hurry up and wait thing, period of time, hurry up and wait. So, we're gonna take some testimony on, what are we taking testimony on?
On psychedelic medicine, the president just signed an executive order that's going to fast track clinical trials. So if we have time, I would like us to hear from some national figures on Zoom. There's also people who, if we could give them enough notice, would be willing to fly to Vermont and meet with us in person, including some possible high profile people. Would make it exciting in the end.
Not Joe Rogan.
Huh?
Michael Pollan. Yeah, how about Michael Pollan?
I'm not going to say their names on the record and then put them on the
The
spot.
problem is we don't know how long we're gonna be here.
Exactly. So it's probably going to be months. So we have plenty of time.
All right,
Okay,
thanks,
thanks.
everybody.
Like, swag.
Coming back after.